For that introduction, respected chairpersons, and all dignitaries, the students. Greetings from Indira Gandhi Institute of Health Sciences, that is where I'm currently working. I take this opportunity to thank the entire organizing team of Be Positive, Dr. Viraj and his team for giving me an opportunity to share a few ideas on this topic, oral health workforce in India, a Swoc analysis. So before I start, this topic is mainly with the undergraduate students in mind. It is a topic which we all are aware of, and I want this to mainly reach that group of undergraduate students who believe that there is no future in dentistry. So before I move on to my presentation, I would like to start with a small definition. I'm not personally a fan of definitions, but WHO, the World Health Organization, defines oral health as a state of being free from mouth and oral pain, oral and throat cancer, oral infection and sores, periodontal disease, tooth decay, tooth loss, and other disease and disorders that limit an individual's capacity in biting, chewing, smiling, speaking, and psychosocial well-being. Why I read out this definition is this is one of the most comprehensive definitions of oral health, which includes all the dimensions. Now let me move on to certain alarming statistics. Out of the 291 diseases that have been studied for global disease burden, dental caries occupies the first spot. And severe periodontitis remains the sixth most prevalent condition in the same study. About 50 million of the 35 about 50% of the 35 million HIV cases manifest oral infections. 50% of 8.5 million deaths occur annually is because of the oral craniofacial trauma. And oral cancer globally is among the most prevalent cancers. And hence, oral diseases are usually considered invisible or hidden and is always accepted as an unavoidable consequence of aging and life. So let me take you to a very familiar concept called iceberg phenomenon. This iceberg represents what is the occurrence of disease in the community. As you all know, when you talk about the iceberg, the nature of the iceberg is that whatever is seen above the sea level is very little compared to what is buried below the sea level. So when we are trying to tell about the disease occurrence in comparison to the iceberg, the top portion is the visible portion are the cases which are already diagnosed. Either the patient knows that the disease has already occurred or the healthcare provider has identified the disease and the treatment process is on. Whereas the invisible portion is a conglomeration of misdiagnosed cases, undiagnosed cases, or subclinical cases, unidentified cases. So this actually forms the major chunk of a disease burden in a community. And being public health professionals, we are more focused towards the lower part of the iceberg, trying to identify these diseases and convert them to the visible so that the healthcare providers can provide treatment for that. So, what exactly is a public health problem? That is, for a disease to be identified as having a public health concern, it should satisfy 4 criteria. Any disease that is having a good prevalence in the population, which has an impact on the society, impact on the individual, and the problem is preventable and effective treatment options are available, such a kind of problem is termed as a public health problem. So by this definition, most of the oral diseases that we come across, be it dental caries or gingival or periodontal disease, malocclusion, oral cancer, fluorosis, all of them are considered as public health problems and require a public health approach in managing these problems. Now, how do we manage these problems? On one hand, if you talk about the global scenario or the Indian scenario, we don't have a dearth of cases. We have a lot of disease burden in the community. And if you are going to tackle this disease burden, it is mainly by the oral health workforce. The oral health workforce is basically comprised of dentists. In dentists, I also include the undergraduate students and house surgeons and also the dental auxiliaries. So these are the manpower who are given the responsibility of tackling these problems in the society. So, one interesting article I came across in the British Dental Journal that was given in the year published in the year 2017, wherein it is titled as "Why Dentistry is a Great Career." So, taking some excerpts from what is published there, it is mentioned that you don't just jump into a job that is unique even within the realms of healthcare, dentistry stands apart. It is half business, half clinical, incredibly intimate job, and with the potential for great impact. And it focuses on a part of the body that deals with the confidence, general health, etc. So this is the scope that is mentioned about dentistry in a British Dental Journal article published around 5 to 6 years back. But the same journal, 1 year before this, there was another article regarding what is the dentistry scenario in India. So that is titled Dental Education, Too Many Graduates in India, wherein it is mentioned. This was also shared as a part of the D+Ve brochure. This comment was also shared, wherein gone are the days when dental profession is considered as elite and luxurious. The whole writing regarding dental profession is totally negative, both coming from the same journal, which is just 1 year difference. But one is the Indian scenario and one is the Western scenario. So what exactly makes this problem evident in India? I don't know how many of undergraduate students are there here, but the main intention of this presentation is to analyze the strengths, weakness, opportunities, and challenges the dental health workforce faces in India, so that we can probably get an answer to what exactly is the situation regarding the oral health workforce. So by meaning SWOC analysis, I'm sure all of you are familiar with this terminology, we try to identify the strength. That is the first thing. Once you know the strength, you know what is your scope, where you can build up. The second is you need to address the weakness, because the most importantly, we have a set of weakness. Once we identify them, address them, we need to convert them into our strengths. The third is we need to explore or exploit what are the opportunities that are available. And fourth is we are to manage what are the challenges. So once we recognize our caliber or our potential under these four headings, we need to know what is the road ahead. So first, coming to what are the strengths of the profession of dentistry in India. We boast of a very organized sector. I'm sure you must have read this in public health history. We have an organized system of delivery of healthcare. We have a lot of options available for delivery of healthcare. It could range from public programs or public sector, the government sector, the private sector. Then we have indigenous systems of medicine, which also, in fact, acts as a mainstream system of medicine in the states like Kerala. We have voluntary health agencies associated with providing healthcare, and around 45 running programs on a national level which address the topic of healthcare. So this organized system of healthcare is definitely a plus point. Next is another controversial topic. I call it controversial deliberately because when we talk about dental workforce in India, this statistics was taken from yesterday's DCA website. We know that we have around 2,95,696 dentists practicing in the country. I mean, according to the Dental Council of India website. Okay. So, simple mathematics, we have the population is around 1419, 163, 147. This is the approximate population that is available as on yesterday. And when we have the number of dentists, 2,95,696 dentists, when you just divide the population by the dentists, you get a number 1:4,799, which is called as the dentist population ratio. Now, many of the, when we do a literature search regarding what is the career option of dentistry in India, most of the blogs come up with this kind of statistics saying that in a developing country like India, we need to have at least 1:7,500 as a dentist population ratio. But our dentist population ratio is much better, and we say that we have excess of dentists in our country. But this calculation is actually a misnomer. This is not the way a dentist population ratio has to be understood, because this, so according to the WHO recommendation, it is 1:7,500 for a developing country and 1:5,000 for a developed country. Now, the basis for calculating this dentist population ratio is total number of dentists who have registered in the Indian Dentist Register since its inception. So this 2,96,000 is not effectively the number of dentists currently practicing dentistry. When we talk about oral disease burden, we are concerned with dentists who are practicing the profession of dentistry. So this register, which came right from late 1940s, is still having a cumulative score of 2,95,000. Out of this, there might be a good number of people who have retired from the profession of dentistry. There will be a good number of people who have changed the profession of dentistry, gone abroad, even their number comes. And as a matter of fact, even for, if I take my example, I finished my graduation, post-graduation in Karnataka. I got a registration there. I moved on to Kerala. Now, if I log in my name, I can get 2 entries. Me registered with Karnataka State Dental Council, though it is not active, but my name is included in that 2,96,000. So that very well says there are some amount of duplicate entries, and you should not confuse this dentist population ratio as the actual dentist working force. And the working force must be just 1/3 or very less compared to what is projected as the total number of dentists. So that is why I was telling the dentist population ratio to determine what is the scope of dentistry in India is totally baseless. Next, we have a good number of auxiliary availability, though not all auxiliaries are available in India. In India, we have dental hygienists, we have dental technicians, the DORA, and the dental receptionists who are the backbone of the practicing dentists in the country. And of course, when you talk about the government oral health care, we have an affordable health care in the government system. It's not that though we have an organized structure, whatever healthcare is available in the government sector is definitely affordable. So affordability and accessibility are the main issues that prevent people from getting the dental treatment. So these two issues to an extent are sorted out. That is our strength. And in the past 2 decades, and in the same article, it was written that there are around 310 dental colleges. But when we look at the number of colleges, there has been definitely mushrooming of colleges, but there has been in continuation, there has been an increase in population, there has been an increase in the oral disease burden every year, and there has been an increase in oral literacy. So this number of training capacity is actually a strength wherein we are getting a lot of dentists trained in order to deliver oral health care. And of course, of late, we have seen numerous advances taking place. All the topics today that were discussed, they are all focusing on dentistry of future. A lot of technological advancements, including your 3D printing or lasers and implants, it is very fast evolving. In the dental conferences, such platforms are truly occasions where we get to know and share these knowledge about these new technical advances. So technical advances in dentistry is proceeding at a very rapid rate. And of course, cost-effective dental treatment. I don't tell dental treatment is totally cost-effective, but compared to other countries where India is one of the most preferred locations for dental tourism. So it is very cost-effective when many people it works out even if they come with, it includes their flight charge and treatment charge, it works out to be cheaper than what is there in the country. So in that aspect, dental treatment is definitely cost-effective in Indian scenario. And one of the most uniqueness of the training system of undergraduate, I don't know if all of you have recognized this uniqueness. Dentistry is one of the courses, or probably the only course, where the dentists start treating the patients right from their undergraduation. When they enter the 3rd year of their undergraduate curriculum, they are handed over patients. This is one of the most unique aspects. That is why when I told about the dentists as manpower, I also included the clinical dental students as well as the house surgeons. Because no other stream of healthcare directly allows a patient to be treated by an undergraduate student. Of course, it is under the license of the faculty member, but this system of training is quite unique, which we can boost in dentistry. Next, so these were our strengths as dentistry as a profession in India. Next, coming to what are our weaknesses. This is what we need to identify, and we need to know methods how we can overcome these weaknesses. The first weakness is oral. Of oral disease has not yet been quantified in the country. That is where why we need to measure this oral disease burden is it helps in prioritizing the actions, it helps in planning a program for preventive action, it helps in assessing the performance of healthcare system currently there, it helps in comparing action and health gain, it helps in identifying high-risk populations, it helps in planning for the future need and setting priorities in health research. Though we say dentistry is not given much of priority, one important reason for that is we don't have a correct data regarding the oral disease burden. When you talk about the data that is already available, there are a few sources. There is one study which was conducted in between 1990 and 2015. Then these are all the few references what we have, what we refer for assessing the disease burden. But the basic limitations of the existing literature is we don't have a census type of data. It's all done on small samples. which when we try to extrapolate it to the population, it might not work out. We don't have a uniformity in recording these diseases. There is an absence of universally accepted index where we can measure the disease. There is lack of authenticity and validity of data, and most of the diseases are quantified based on prevalence, which is not the right measure for oral disease burden. Second is, though we have an organized healthcare delivery, we don't have dentists at the primary healthcare level. That is another weakness that we have. And the dental services basically start from the secondary care. That is from maybe private hospitals is where we find the first contact point for the dentist. We don't have dentists at the primary healthcare. Third is the geographical divide. According to the recent census, the rural is to urban population. We have around 70% of the population staying in the rural area where only 20% of the dentists are practicing. And on the contrary, we have 30% urban area where most of the dentists are practicing. This huge rural-urban disparity has also had an influence on the oral health workforce. Fourth is again an affordability issue. Though our country is much affordable as far as dental tourism is concerned, there are a lot of affordability issues. That is the reason why the population do not seek oral treatment. That is one of the predominant barriers for seeking oral treatment. And probably the cause is because the products that we use, most of them are considered to be luxury products rather than therapeutic products. So the tax levied on this, all the import duty levied on all the items that we use for our dental treatment is what is making the cost higher. So that is one of the primary reasons affordability is a major factor. And of course, we all know dental insurance as of now is standalone dental insurances are very minimal. Whatever we get is either as an ancillary benefit for a health insurance, but we don't have standalone dental insurance package. What makes dentistry fare better in the West is basically the involvement of dental insurance, because there people are more focused on prevention. They have a coverage for dental treatment, and hence the utilization is also increased. So we don't find that as of now in India, but of course that is only a temporary weakness because many companies are now trying to come up with exclusive dental insurance. And limited government dental colleges that are offering oral care. We see as the year passes, we see more of privatization in dental colleges. And when we talk about the budget allocation, we find that according to the GDP allotted for healthcare from the central government is around 2 to 2.5%, but there is no separate oral healthcare budget allocation. Similarly, also in the state government, around 6.5% is the budget for healthcare last year, but we don't have a separate budget for oral health. And of course, the low oral health seeking behavior. Oral health seeking behavior refers to the action taken by an individual to preserve or gain good oral health, and it's affected mainly by the accessibility and affordability and poor oral health literacy. And low perceived need for oral care, wherein people are more oriented towards treatment rather than prevention. That is what we call as a downstream approach. Upstream approach refers to prevention. So main is focused on treatment rather than prevention. And very few government-run programs exclusively for oral. So these are the points which highlight the weakness of the existing oral health workforce in our country. Now, what are the opportunities? Now, why I went into all these weaknesses in detail is we can be positive, because what I'm going to tell now is regarding a national oral health policy. I don't know how many of you are aware of such a policy, because as soon as the government drafted there was an Almata Declaration in 1978, which said there has to be health for all by 2000. And immediately a health policy was drafted in 1983. It was accepted and it has been revised, that is going on. At the same time, there was a draft national oral health policy that was drafted in the year 1984. It was again discussed in detail in 1994, and in 1995, such a policy was accepted by the government of India. But sadly, it is not implemented till date. But one good news is that since the latest revision of the 2017 National Health Policy, there has been movement positively in this regard. As of now, the status is this oral health policy has been accepted and is going to be implemented soon. Now, why I'm talking about this oral health policy is what all guidelines are mentioned in the oral health policy, though it was drafted around 40 years back, holds good even to the present scenario. All the weaknesses, most of the weaknesses I told you is covered when this policy gets implemented. I'm just going to give a brief highlight about what are the recommendations of the policy. The first recommendation is there has to be oral healthcare professionals right from the village level. That is, we have the Anganwadi workers, the ASHA workers. They don't have a focus on oral health. They need to be trained regarding oral health. That itself will initiate an oral health literacy among the population. Second is at the sub-center level also, there has to be training on multipurpose health worker, male and female, regarding oral health. Third is at every primary health center, there has to be a service of one dental surgeon. And this itself will tremendously increase the scope of dental services or dental opportunities in the public sector of the country. At the community health center of the Taluk hospital, you need to have 2 dental surgeons, including a specialist. At district level, at least 4 dental specialists. State level, there has to be a separate director of oral health services. At national level, an additional director general for oral health services with a separate budget allocation. And involvement of school teachers, NGOs, mass media in promoting oral health chapters in textbooks. Other than dental formula, we hardly learn anything during our schooling. So there has been an emphasis on chapters related to oral health. Then statutory warning on sweets, and importantly, exemption from tax for products that are used in relation to dental treatment and oral health maintenance, which is going to drastically reduce the cost involved in dental treatment. And this is the latest update, which was just circulated about a month ago, that's saying that the policy has been approved again and it is going to be implemented very soon. So let us be positive. One such change in the dental sector can address most of the weakness that was already discussed so far. Second opportunity is many of the school oral health programs are planned, especially by the dental teaching institutions, that lay an emphasis on the primary oral health care and increasing the awareness of oral health among school children. And of course, as I told you, dental insurance is slowly evolving. A few companies now are started offering dental insurance. That itself will have it will be a major boost as far as the treatment need is concerned. Then there is an effective utilization of institutions in promotion and enhancing community participation and reorientation of services. All this mainly is based on the involvement of dental teaching institutions. Definitely, it is going to have a major impact. It is an opportunity in order to improve the dental workforce in the country. And of course, there are some challenges and threats which need to be addressed. First and foremost is the low priority of oral health in health system and rising burden. There are so many dentists available, basic dental workforce is available. The research shows that there is an increase in the disease burden. Third is the low oral health seeking behavior that already was discussed as part of fitness. And most important, compartmentalization of oral health. What is meant by compartmentalization is dentistry is considered compartmentalized. So this amalgamation of oral health into the dental healthcare system is the need of the hour rather than a compartmentalization. So that itself is a major hindrance for effective implementation of programs pertaining to oral health. And on top of that, because there is increased number of graduates, of late we have been hearing a lot of unethical practices. Unethical practices include marketing, there could be advertisements, and there offer free treatment. All these are those which are supposed to be considered, which are unethical, have started getting into practice now. Again, it is due to the survival. So unethical practice is a major challenge of unethical practice. And we don't have an organized system for monitoring healthcare services. Probably once this oral policy comes, most of the things is going to be addressed. And of course, not much in Kerala, but in other states, there is still a system of quackery wherein we have a roadside dentist, street dentist practicing the profession of dentistry, and that is a major challenge. So I would like to conclude by saying that the situation as of now is not as grave as you think, or is as reported by the dentist population ratio, which is considered to be one of the key indicators. There are opportunities. These opportunities will help, and once we recognize the weakness, we possibly can convert it into our strengths. Because as a dental professional, we have multiple roles to play. These include primarily we are clinicians, definitely. We could be counselors, we could be health educators, we could be role models, we could be researchers, academician, leader, opinion builder, and alliance builder. So once you pass out of your dental school, you don't know what kind of role you are going to accept. So whichever role is there, it is definitely going to do well. It is going to do good to our dental profession. So with this note, I would end my presentation. I thank the organizing team, sir, the D+Ve, the entire team for giving me this opportunity to share this idea with you. Thank you very much.
Thank you, sir. Thank you for making us aware on the topic of oral health.